Hello, I'm Eric Garcia. I'm a nurse practitioner student at UTEP for my acute care adult geriatric nurse practitioner postmaster certificate. I'm going to be going over first the primary survey and trauma assessment as well as the secondary survey, and then I will add in a eFAST exam at the end with some tips and pointers to basically go over what's needed on the eFAST exam. I'll go over that a little later, but let's start out with the primary survey. This primary survey is organized according to the injuries that the patient has sustained in the trauma wreck or whatever the incident may be. So, whatever you see most immediate to danger is going to be where you're going to start your survey. Pre-arrival preparation, make sure you connect with EMS. Any information you can get is going to be good. So the more the better. EMS should notify the hospital that a trauma patient is en route. Notify hospital staff and anyone involved with their care should be aware. Start with the basic patient identifiers: age, sex, mechanism of injury. Then go to vital signs, and again, obvious injuries should be focused on, especially if they're life-threatening, and they should also be included in the EMS report. But as we know, what should happen isn't always what happens. Easy mnemonic, we all know with the primary survey, is to use your ABCs, which A stands for airway. So assess for airway, as this would be the most immediate risk for any type of permanent injury or immediate injury at that. So assess the airway, also maintain cervical spine stabilization when it's appropriate. Check for airway obstruction by the tongue, foreign body, any aspirated material, any edema, any blood, hematomas, and again, aspiration. Next would be breathing and ventilation assessment. This goes different from the airway, so I would always go with breathing and ventilation. More if they're conscious, have they gotten anything to stop them from getting the breathing done, a crushing injury, some kind of pneumo, broken ribs, things like that, as opposed to actually focusing on the airway. Circulation would be next, so this entails hemorrhages as well. So if you do see obvious bleeding, initially control that. Maintain adequate perfusion. This can be done by even just checking skin tone, temperature, capillary refill, and also, if possible, insert large bore IVs. Disability assessment is next. That would be where the D comes into play. And this would just be basic neurologic evaluation out in the field, sensation, strength, things like that. And you don't need to do a full NIT. The E stands for exposure. What might they have been in contact with environmentally? Undress the patient, search everywhere for possible injury, and also prevent hypothermia, especially if there's any burns involved. So again, just to review those, it's A for airway, B for breathing, C for circulation, D for disability, and E for exposure. You can assess the airway on a conscious patient and also their neurologic function at the same time. Ask them their name, have them follow a command, ask them what happened. You can get a lot of good information this way. And they'll also tell you if they can themselves protect their own airway. Assess and observe for any facial, head or neck trauma. This can cause some disfiguration of the airway. Also assess the chest and abdomen for signs of difficulty breathing. That would go more along the B. And if you notice anything abnormal, asymmetry, really working on it with accessory muscles. Assess the oropharyngeal cavity for missing teeth, displaced tongue, pulling of blood, secretions. Things can kind of hide back there, so don't be afraid to open it. Kind of get a good eye on it. At this point, if anything's off, you can also start assessing for endotracheal intubation or a laryngoscope if needed. Examine and palpate anterior neck for trauma, edema, hemorrhage, or any crepitus could have happened from a pneumothorax or a hemothorax. So go ahead, lightly palpate. Should be your last part of the exam. If the patient is unconscious, there's another mnemonic you can use. It's called lemon, LEMON. The L stands for look. You want to look for trauma, anything obvious, as we already went over. E would be evaluate. So evaluate the mandibular distance between the hyoid and thyroid. Intraoral structures, of course. If they have a C collar at this point, go ahead and remove it. If they don't, go ahead and focus on stabilizing the C spine, but you do want to remove for a proper assessment. M stands for Malampati classification. This would be just judgment for intubation, how close those tonsils are. So go ahead and open their mouths, and this will also give you a good opportunity to check for the foreign objects, as we previously mentioned. Much of this stuff overlaps, but this is for an unconscious patient. O on lemon stands for assess for obstruction of soft tissue edema. That may make intubation necessary or complicated. N is for neck stabilization. Like we said, we got to maintain C collar. If it's been removed, make sure it should be maintained and reapplied at the earliest possibility until cleared from C-spine protections. This will most likely be done by trauma specialty. And then after everything's been assessed through the A, B, C, D, E's, and you can use your mnemonic of lemon for the unconscious patient, go ahead and start wondering, what do we need to do for diagnostic studies? Are they hemodynamically stable? Can we move them from here? What are our assessment findings? Have they improved? Are they getting worse? Kind of take a little step back after you've initially assessed and intervened. Right off the bat, it's going to be probably pretty hectic. Should have a team with you, but at some point you need to step back, reassess, see how everything worked. Go ahead and start thinking about maybe some penetrating injuries to the abdomen, back, chest. So log roll if the team is appropriate. Start checking them out back there. Consider x-rays, CT scans, and also ultrasounds. If the patient seems to be stabilizing, which I hope they will, and if not, it's not good news for them, we'll begin the secondary survey. So this begins after resuscitation and the patient has been stabilized, if the patient needed resuscitation. This survey is going to be a little more thorough, a little more attention to detail compared to the primary survey, which is just gauged at what you see first being the most imminent threat to their safety and immediate threat of death, really. So this one, you're gonna, like I said, be more thorough from head to toe. It's aimed at finding only life-threatening injuries. Like the primary survey, it's aimed at not only finding life-threatening injuries like the primary survey, but other significant injuries that may cause debilitation later, deformation, anything with lasting effects. If the patient does decline in status, of course, go back to the primary survey, see what the biggest issue may be at hand, and proceed to resuscitate, obviously. But, I feel that's important to highlight regardless. Sometimes the obvious is what's overlooked the most. If you can, start with the history. Again, important to use all resources available to you: patient, bystanders, any medical emergency personnel, family, if available. There's another mnemonic for this one. It's called ample. So that one I remember because you want as much as you can. You want as much as you can get. You want an ample amount of information when you grab the history. So A stands for allergies, right? We don't want to give them anything. We're going to put them in a worse situation in the beginning. M is medication. Have they taken anything? Anything caused them to be here, or what might they need in the near future? Say there may be seizures, AFib, who knows. P would be past medical history and tetanus status for obvious reasons. What led us up to this, complications to look out for in the future, and if it was trauma, obviously tetanus, if there was any penetrating injuries or even lacerations with any dirty metal. L is for last meal. This will give us good insight into possible aspiration, intubation. Also, even if you want to really get into it, the parasympathetic nervous system and those responses. And E for events leading up to the injury, which is pretty self-explanatory. So again, it's A for allergies, M for medication, P for past medical history, L for last meal, and E for events leading up to the injury. Ample. I'm going to go ahead and go over the exam head to toe just for ease, and hopefully you can continue to repeat this and get a nice little flow of things. All injuries should be documented also as accurately as possible, even if you're in the field. Hopefully the secondary survey isn't in the field, but you know, it's possible. Maybe we're in the middle of nowhere and we're waiting for people once we've stabilized the patient as best we can with EMS. So starting with the head and face, much of it's going to be the same as the primary survey. You're going to look for lacerations, any bruising, any mastoid, or periorbital especially. You know, sometimes you can miss these. You want to look at the eyes for any foreign bodies, any trauma, bleeding, irregularities. If they're conscious, go ahead and check for eye movement. Ask them to look here, close this, squeeze this. Check the ears if there's any CSF leak or any bleeding coming out behind the tympanic membrane, as well as the nose for any CSF leak or any other bleeding or deformities that are obvious. And again, the mouth for laceration, swelling, teeth, debris, things like that. And then go ahead, after you've done an initial visual assessment, go ahead and palpate, you know, the orbit, the skull, see if you find any dents, the nose, the jaw. Check behind their ears for any bruising. That could be also very important as well. Then go ahead and move down to the neck. A lot of times plain lateral neck x-ray is indicated to clear C-spine. It won't be determined by us, but something you should be aware of. If they do need a lateral x-ray, cervical collar should be removed and manual inline stabilization should be used during the x-ray. This normally requires 3 persons, but more is better. And again, after the x-ray is taken, go ahead and reapply that C-collar. If able to log roll, the vertebrae should be gently palpated for any obvious deformity or abnormalities, as well as the trachea should be checked for symmetry if it's midline. Also check if any abnormalities, even crepitus again with pneumothorax. This is after your initial visual assessment, which would look for bruising, bleeding, the same stuff, skin color. You can also check the larynx for tenderness or crepitus. This could be a laryngeal fracture. Don't palpate firmly. This can cause an obstruction, so be very careful when you're palpating the larynx, okay? Look for distension on the veins. That could also be a sign of pneumothorax or pericardial tamponade. Check the esophagus, see if the patient can swallow if they're awake. Ask them to swallow, ask them to talk to you. If this is difficult to swallow for them, the esophagus may be injured. And if you hear any muffling or anything like that, that's definitely an emergency. And reapply the cervical collar once this is all assessed. Then we go ahead and move down to our chest. Again, start visual. Anything obvious, any obvious injury signs. Palpate for rib tenderness, again, sub-Q emphysema. Don't forget the collarbones. On skinny people, this will be easier, but if they're overweight, you're going to want to make sure their supraclavicular fossae is present, all ribs, both axillae as well underneath the arms. With that log roll, when you were checking the cervical spine, go ahead and check if there's any occult blood hanging out behind them posteriorly. When you log roll, again, auscultate the lung fields after all visualization has been done. Note any differences, wheezing, crepitus, gargles, and auscultate the heart sound. And again, assess for quality of beat, the location of the apex, and any abnormalities, rhythm-wise, muffle-wise. We know what a good heart should sound like. Next, move on a little further down. Inspect the abdomen. Any obvious injuries, especially seatbelt marks, go ahead and document those, don't forget. Then you can go ahead and auscultate, see if you hear any bowel sounds. Begin to palpate over the liver, right upper quadrant, the spleen. Kidneys are going to have a hard time, but in the back, and then suprapubic for the bladder. Check the pelvis with an x-ray if you think there may be a possible injury. And you can also gently palpate for tenderness, but don't spring the pelvis when you push it up and just kind of let it go, or you push it down to kind of spread it out to manipulate it. This can cause worsening hemorrhage if they had a bleed in their pelvis, which is going to be hard to find initially anyway until way later in the game. So don't manipulate the pelvis hard. That's an important thing to keep in mind. and also inspect the perineum for any signs of injury. This is going to be a little awkward if they're awake, but again, we need to strip these patients down. Who knows what they've come in contact with, and I mean, this could be a life-changing thing, especially, well, for anyone. Then go ahead, we'll move a little distal. We're going to check out limbs. All of them should be inspected in similar fashion, like we discussed, starting with visual inspection, color, warmth, movement, sensation, capillary refill. Go ahead and start palpating for bony and or soft tissue tenderness. Check their joint movement, stability, and muscular strength. If they're not awake and they're not going to comply with you for muscular strength, that's fine. But even still, you can still bend things, twist things, see if they're stable. And again, if they're conscious, also check their sensory and motor function. Then we want to move to the back. Go ahead and log roll your patient. If possible, try to do this only one time. So when they're on their back, when they're log rolled, check their flanks, check their cervical spine, check their ribs, check their skull in the back, and maintain C-spine the entire time. More people, the better. Check for bruising, lacerations, deformities. If spinal cord injury is suspected, a rectal exam should be performed to assess if there's any loss of tone or sensation. Also, go ahead and inspect the buttocks and perineum as mentioned before, but this time from the back, and anything obvious, go ahead and note that and address it. Any deformities, any blood, same things. And then also the genitalia for the front side. Any soft tissue injuries, and note any priapism with a spinal injury that could be present. And after that, hopefully they're stabilized, they're chilling in bed, and they have their C-spine on. We have trauma coming on board to further evaluate, and our patient is stable. So that concludes our primary and secondary survey. Now we will go over a eFAST exam, which is an ultrasound used on the abdomen to assess for any free fluid, basically. Very simple, very cost efficient and easy to use, and the more you do it, the better we'll get. So we'll go over some main aspects there coming up, and that's all. Thank you. This is the eFAST exam. I will be using a remote control to substitute for my ultrasound machine. We basically want to highlight four main quadrants: the left upper quadrant, the middle where we can assess for the pericardial, left upper quadrant, and suprapubic. I will go over each one, and a nice technique to kind of cover all of them in a nice clockwise manner. You want to start mid-axillary, right upper quadrant, feel the ribs, kind of get to the bottom of that, and you can kind of point it up, and cerebral, mid-axillary as you want to start, and this will help you detect for any free fluid around the liver, and then you can kind of slide backwards and look for any right kidney or hepatorenal recess. This can hide within the Morrison pouch, and you want to go ahead and check for any fluid in there. And then you also want to go ahead and slide your way back up, and after that you can continue on to the anterior thoracic view. This is at the highest point of the chest wall. It can be right under the xiphoid process right here. You can go ahead and feel that, and from here you can go ahead, kind of point this way and up, go under them. I would go a little harder, but I do have a very awake in life patient, and it will hurt if I kind of dig under there to view all four chambers. But this is to detect if there's any free fluid around the card, any pericardial sac, pericardial tamponade. After that, hopefully you can see all four quadrants, but again, you just want to find that mid sternal area, find the xiphoid process, and go ahead and use your ultrasound to get up underneath and view any free fluid that may be around the heart. Go ahead and continue on to the left upper quadrant, and again, you want to start with the mid-axillary line, find your ribs, try to get up under there, and here you will try to detect any free fluid around the spleen and the left kidney, including a splenorenal recess, much like the other side with the liver, but here it's the spleen. This one's called the collar pouch or collar pouch. If you're having a hard time finding the spleen and the kidney, you can go ahead and try to rotate clockwise, give it a little twist, and you can probably help separate them a little more. And go ahead and slide back forward on both sides. Actually, I forgot to mention it over here. When you slide, you want to see that lung base kind of slide back. You kind of catch it and go this way, and it should slide back on your transducer here. And with that, if it doesn't slide back, you probably have a pneumothorax or a hemothorax. Okay, so after we finish here, you want to go ahead and slide your way on down. Lastly, to the pelvic view here above the suprapubic. So find your pubic bone and go ahead. This would be, of course, behind the clothing, and this will detect any free fluid in the rectovesical excavation, or also known as the pouch of Proust, or pouch of Douglas. This is going to be a little more difficult, especially if the patient recently voided, but you just want to check this and see if there's any free fluid, possible blood, and anything like that. This one may be difficult again if they have voided, but that's basically it. After you kind of work your way a little clockwise system here, you'll go ahead and finish an eFAST exam, and as mentioned before, I would recommend this after the secondary survey, as the primary and secondary survey are easier to be done initially to see if there's any obvious signs of trauma that need to be addressed at that point. Thank you.